Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. In episode 5, we find ourselves in Dallas, Texas, USA, with none other than Rod Rohrich speaking to us about achieving consistency in rhinoplasty.
I'm going to look up some of the questions that have been asked, and let's go through some of the
Sure.
questions.
Okay, we'll take off the share.
Okay, so the first question here is, sir, do you do tip debulking? Question mark, subcutaneous fat? Question mark.
Do I do tip debulking? I do less tip debulking in primary rhinoplasty. I do it in secondaries because there's a lot of scar tissue. In primaries, I don't like to debulk the tip unless I have to. I'll put a suture in there, and I think this is something that we're learning from the preservation rhinoplasty folks, is because I think you can use that, Patanki's ligament, you can suture it back down probably to the soft tissue. So I do less debulking. In secondaries, I do, and then I try and close that dead space if I can. But if I'm debulking a lot in a secondary, those are the people, that subset that I will be injecting Kenalog in postoperatively early, starting at 2 to 4 weeks. So don't.
Thank you.
Okay.
Okay, I've got another question from Karen. It says, in a badly depressed or saddle nose with a tight skin envelope, the use of diced cartilage and fascia versus a rib strut? Question mark. I had a patient where I used DCF, and 2 months later, the DCF had depressed back.
I'm not a big fan of diced cartilage. I personally don't think it works well, because if you need structural support, you need a rib graft. In a saddle nose, if they have a real tight envelope, many times I will actually put fat in there, and I'll inject fat in the office and let it sit and have them massage it for about 6 months. Then then I can probably go back, because 2 things happen. The skin will look better. I got a fat interface to the scar tissue if it's really, really thin. And then I'll come back and then I'll do a solid rib graft. I'm not a big fan of diced cartilage and putting it in and hoping for the best. I think it's a good accessory if you want it to fill in a concavity, but not for structural support. I mean, I know Wolf has talked a lot and does a lot of both, but I don't know. I've not been good at doing diced cartilage.
We're going to be having a talk by Dr. Nassif on Thursday on diced cartilage, so it's going to be quite interesting to see what he says there. I'm going to move on with the next question. Dr. Rohrich, thank you for this nice talk. What do you think about the long-term changes in the alar-columella relationship after rhinoplasty by aging? For example, alar retracting and columella hanging in 10 to 15 years. Yeah. What percentage do you need alar contour grafts?
Well, I will tell you that's 100% accurate. As we age, our alar rims sag, our nostrils sag, our columella lengthens. That's why I probably in 40 to 50% of my facelifts, I do a rhinoplasty, and I do primarily the tip shaping. I actually do the thing. I put in extended alar contour grafts. I resect the little caudal septum, because all those things happen. Our nose droops, our alar rims droop. So I would say it's categorically a thing to do. And almost in 100% of patients, I put alar contour grafts. It's one graft that you will never be sorry that you used. Never. And I don't say that about any graft.
I find it very finicky. It can be difficult, and often I'm doing it at the end of the operation.
Absolutely.
You're getting tired, you want to move on, but it's worth that little bit of extra effort.
Yeah, you got to do it, and it's smaller than you think. And then many times, you can suture into place, and you can do like Rick Davis is the champion of. He puts in the fixed grafts. He tension bands the tip, and then he puts in grafts. He sutures them to the tip, and then he slips them in before he closes, and he has phenomenal results. The tips are a little bit more rigid. You just have to tell your patients that.
Okay, thank you. There's another question here. it's a question. Sure, they're rolling in lots of questions. Do you ever remove mucosa from inside the nose?
Yeah, absolutely. When I have a hanging columella or a real big nose, like in that one patient where I showed, I resect mucosa, because if you don't resect mucosa in those large noses, once you've shaped it, you'll get nasal airway obstruction. And so when I'm done, if I can take my brown acid and pinch it, and then I'll resect the mucosa and do it on a differential side on each side and you close it. It's great, but it's a beautiful thing. If you're not, guess what? You'll obstruct the internal nasal valve distally. And so, yeah, I resect mucosa, but not inside the nose, very uncommonly, but the membranous septum, I resect mucosa there, not infrequently.
Thank you. Antonio Vieira's got a good question. He says, your mobile extensor has any difference from the ANSA banner, which was described by Carlos Neves?
I don't know. I don't know how it would be different.
Yeah.
I'd have to look at it, but I've looked at septal. I like septal extension grafts in the past, but I just didn't like because they were so rigid. So I've just gradually gone to this. And the other reason I like it, it's really almost, it's like double the size of a columellar strut. So you don't need that much septum. With a septal extension graft, a true one in the end, you need a lot of cartilage. And I'm already using it for alar contour grafts and things like that.
Yeah. I'm definitely going to try that. That's very interesting. Okay, I've got another interesting question here. Why do you perform spreader flaps before osteotomies and closing an open roof?
Well, the reason I use, first of all, I use pull, twist, turn. I actually do spreader flaps first, and then I do my osteotomies. The reason I do that is because I used to do it at the end, and you know what mistake I made? I was at the end, and I had done the tip and everything, and I didn't reassess the dorsum, because after you do your osteotomies, you got to look at the dorsum. It's got to be perfect, and if it's not perfect, then you have some irregularities there. So I now do it at the beginning, and then after that, I rasp it, take it off, and then I put in final buttress sutures for the Texas sutures. So I think you can, if you do precision osteotomies, whether you do percutaneous preservation or you do them with piezo, it's so easy. It's changed my life on revisions on the dorsum. Try it.
Awesome. I'm going to carry on going through some more here. A question about the side effects of the TXA and if there are any restrictions on that.
I think, at least in the USA, it's been used for over 30 years, and our FDA, as you know, is not easy. It's antifibrinolytic. It works beautifully. I use it in every rhinoplasty and every facelift, and sometimes on secondary and tertiaries. If it's bleeding a lot, I'll use another gram. You can use 1 to 2 grams in most patients pretty easily, and then I mix it, and so I mix it with equal amounts of lidocaine and epi. So you have the epinephrine effect, the vasoconstrictive, and then you have the thrombolytic effect. You put them together, and you put it in place, and then it's a hemostatic agent. It works beautifully. Fantastic. So I like it. And then also at the end, you want to have a dry nose, right? You want to have a dry nose.
Here's another interesting question about the use of steroids to decrease the dead space and swelling. When to use it, intra-op or after?
Sometimes in really bad revision rhinoplasties, I will put a little Kenalog in at the end. Usually they're ones that, honestly, they're usually ones that I had to do my own revisions on, and they come back and they're just thick scar. I'll take it down. I'll put some Kenalog in, and then those are the ones I'll inject maybe at 2 weeks, 4 weeks, 6 weeks, 8 weeks, because I know, you're fighting the wound healing process, even if you do all those principles of dead space closure. And then on those things, when you've done it yourself, you just have to do. I mean, I've put in Kenalog. I mean, I actually called Dean about, 6 or 9 months ago, because I had this patient that I've been putting Kenalog in for about, and Dean can comment, but I've been putting in like 5, 6 times, and he said, keep doing it till you'll know when it stops working. Go deep. When it finally softens and you see the change. So, but these are these complicated noses. I don't usually use Kenalog in in the typical rhinoplasty, but in the thick skin nose, the revision, sometimes in the male, yes.
Thank you. Okay, a question from Daniel. Do you consider the Patanki ligament reconstruction a thing to do as a way to reduce dead space in the supratip area?
I do. I think that's one of the things I've actually learned from the preservation rhinoplasty folks. I really think that, I've actually done it on a couple of people recently, and, I actually like that. So I'm actually, I think you should always listen and learn. I think that there is a role for preservation rhinoplasty, but I really do. I think that there's a lot of. I think in the primary rhino, straight nose, dorsal hump, with a beautiful, nice dorsum and very little tip work. Yeah.
Okay, that's great. A question here is: what do you think about fat grafting for irregularities?
You know what? I've tried it. I love fat. I use fat all the time in facelifts. Fat doesn't work well in the nose. You know why? There's no subcutaneous space. So I like it if the skin is very fragile, like I said in the damaged skin, I'll put it in. Fat doesn't work if you have a contour deformity. If I have a contour deformity on my own patient that's so minuscule, you know what I do? I put in HA. I put in a deep Restylane. And the amazing thing is, some of it has permanent results long term. Sometimes because sometimes you have a little defect, and the rest of your nose is so good, and you go, oh, I just put a little HA in there, and it's amazing. Sometimes I'll inject them maybe twice, maybe again in 6 or 9 months, and guess what? It stays.
Okay.
So these are in these secondaries, but and again, do you really want to go back on a tertiary rhinoplasty that has a little contour depression? The answer to that is, especially if you've done it, there's no way I want to go back.
Okay, I've got 2 questions around the mobile septal extension graft. The one was that they didn't quite understand the difference between that and the classic one. And the other question was, how is it mobile if you fixed it in 2 points?
Well, okay, I call it fixed mobile because remember, if this is the septum and you put it on one side or the other, and the conundrum here is when do you put it? I try and put it on the side, like if it was deviated to the right, I put it on the left side, but I fix it to the straight. And Dean Doriumi is right because he puts it on both sides because you can cause some nasal airway obstruction, and also if you're doing a rib graft in secondaries, you got to tell them that sometimes they'll be able to feel that and see it. Okay, so I put it on one side. Here's the anterior septal angle. I put it at 45 degrees, and if you can rotate it any way you want. If you want to de-rotate it, you can put it down this way. If you want to rotate it superiorly this way, 2 into the body, then 1 superior to fix it from going superiorly, and then 1 inferior to go inferior. And so it's fixed yet mobile, versus the septal extension graft is this way. It's fixed throughout here. So, and sometimes I'll use a Kayumüller strut if I need it, like in that tertiary. The more damage you have to the nose, the more you'll use grafts.
Okay, I've got 2 questions about the soft triangle. The one is how to prevent soft triangle notching if you're not expecting to develop soft triangle notching post-op. And the second question was, how often do you use soft triangle graft in primary rhinoplasty?
Okay, here, the soft tissue triangle is one of my favorite topics because even when I see perfect results from the world's greatest rhinoplasty surgeons, the soft tissue triangle is deficient. So here's how you prevent it. Don't suture it when you close it. And when you're closing it, again, just like with the alar contour graft, if you have any hollowing there, why do you think I developed a butterfly graft? I didn't talk about that. The butterfly graft is an infiltrate graft that goes transversely here, and it closes the dead space in the soft tissue triangle. So many times when I'm done and I still have a little soft tissue notching and I didn't have enough tissue for butterfly graft from the cephalic trim, I'll morselize my cartilage I have left, or even the soft tissue, and I'll put it in behind the soft tissue triangle. There's a small little muscle there, and when you go in with an open rhinoplasty, you go through that and you get contraction. So don't close it. Close the dead space with butterfly graft. And then the last thing is never suture it, put in an impregnated Bacter band Surgisil. That holds that dead space in place, and it'll imbricate all the blood out of there. it's a little finesse thing, and we're going to talk about it on Saturday. Makes sense?
Yes. Okay. Do you preserve the interdermal ligaments and the scroll tissue of medial crura?
Boy, did Dr. Saban ask me that?
Alessandra asked you that from Brazil.
No, of course, I'm doing an open rhinoplasty. I will restore it. I'm doing open rhinoplasty. I restore it. I suture it back. I close the interdermal ligaments. And I think the Patanki ligaments is something very interesting. I think we need to do more to restore it, to close the super tip break, and to close dead space. So I'm with it.
Okay, so Prof, the questions are still coming in. One question about I'd love to have some live questions from some of the other masters as well. But I'll carry on with the questions that are being asked. The one was on imaging software. What do you suggest? What do you use?
I just use Adobe Photoshop. You can spend thousands of dollars, but here's the thing. You don't want to show a great result. You want to show an average result. Because, remember, you're going to be judged by that. And you always, you saw when you were with me, Cameron, it always said, these are educational views only. I've done it for 20 years. I've never had a patient come back because I always tell them, these are educational views. Remember, I always tell them, I'm not God. He's helping me, but I'm not God. And I operate with a scalpel, not a wand. So basically, I like to give them average results because, especially in secondaries, they come back and they don't like it. I don't operate on them. I send those to Dr. Toriumi. No, but those patients, it helps me weed them out because if they want a little, like they come in sometimes and they say, my right nostril base is asymmetric. And I'm going, maybe, I'm not going to touch those patients. So use it. And you know what? It's really good today. If you're just starting, use Facetune. It works pretty good. Use Facetune.
Facetune.
Yeah. And basically the patient will, the patients bring those in anyway. And, it'll give you a good idea because sometimes some of my ethnic patients come in and they have that turned up, really pinched tip. I don't like that. So it'll give you a lot of information. So I don't think you should invest a lot of money in software, and I don't do my imaging with the patient. I used to do the imaging with the patient there. It tripled the length of my consult. I felt like I was going to a circus, up, down, rotating. So I don't do that. Some people do that. I think that's great, but I have to have a rhythm, and part of my rhythm is I actually do the imaging afterwards, and then I send it to them. That way they can think about it, and I'm not prejudiced. I'm not, they can think about it, and I'm not prejudicing, I'm not being prejudiced to them of, oh, this looks good. It tells me a lot. It's a real.
And when you go to the OR, you take both sets of photos with you, the pre-op photos
Absolutely.
and the morphed images.
Absolutely. And then I go over them with them. And I always ask them, and you saw that, Cameron, when you're with me, I always ask them again, what are your top 3 concerns? I write those down the first consult and then the day of surgery, because you know what? It's called imprinting. Because when they go to sleep, I want them to be thinking what I'm doing. It's temporal imprinting. It's very important for patients, especially in secondaries, because when they come back and say, oh, but these are other things, I said, remember, we talked about the 3 things and those are fixed. Okay. It's just, especially in these secondary, tertiary patients, which, some of them will never be happy, but at least you've done your job.
Fantastic. We've got a lot more questions rolling in. We're going to go for another 7 minutes or so.
Okay.
I'll go through. So there's an interesting question. Does your longer, for minutes, does your longer alar contour graft interfere with your ability to perform alar base reductions? And what happens when you have a patient that needs both?
I do extended alar contour grafts on, and of course I didn't have time to talk about alar bases, but I do them on most patients, and I do alar bases probably in primaries. I probably do alar bases 40-50% of the time. Secondaries it varies, but it doesn't interfere with it at all. And alar bases are a whole nother topic. I mean, that's a whole nother, and And actually, I'm getting ready to publish a great article on alar basis on making it simple. So, which is very, very hard to do.
Yeah, it is. Okay, here's another one. How do you prevent rotation of the dorsal rib graft for saddle nose deformity?
Well, rotation is as big a problem as warping. And, we've all learned the painful aspects of warping. I mean, basically, you want to have a straight piece of cartilage. And as many people, and certainly I've learned this from Dean and others, is that, use an older piece of rib cartilage. I actually laminate my rib cartilages. That's important. And always put the concave one down so that when you're pushing it down on the dorsum of the nose, so that if it does warp, it'll warp up, not up and to the side. And I laminate it, and then I suture it into place hard, just on the keystone area, and I put in 2 or 3 sutures all the way out. And I've made a bed for it on the dorsum of the nose, and if my bed at the end, if it's still mobile, I'll put a K-wire in. I probably do that 10% of the time, and most of the time I try not to. But I'm putting in deep sutures. I know Wolf puts osteotomies through the bone and puts sutures in there. You can do that. I don't do that very often. Sometimes I do that in a really, really, really bad saddle nose, but I got to have it seated. If it's seated at the end and it's mobile, then you got to put a K-wire in. If it's still mobile.
Okay. In secondary rhinoplasty, how can you correct over-resected alar and a narrow dorsum?
You just totally rebuild them. I mean, honestly, alar rim in secondaries, many times the alar cartilages are gone. I totally rebuild the whole tip complex. One should not let don't let the alar rim cartilage stand between you and getting a good result in primary and secondary rhinoplasty, because especially in secondary, they're little crumpled pieces. Sometimes I just throw them away because they've been scarred up. And many times I just throw them away. I make a new tip, septal extension fixed graft, a septal extension graft, and then make new alar rims from rib grafts. I mean, and then it always preserves the scar tissue, because I use scar tissue from harvesting. I use it for the tip to add onto the tip. I put scar tissue on there.
So that's a question now also on the tip is how a soft tip compared to a hard tip. It's quite a difficult question, but yeah.
Well, I mean, I don't like hard tips, but in secondaries, I use a lot of scar tissue to reshape the tip. A lot. I put a lot of scar. So every piece of cartilage I take out, I always make sure that I've actually preserved it. Because many times I'll put tip grafts on scar tips from the scar tissue itself. I'll put it on the tip when I've got rib grafts, and then on the dorsum. I like mastoid fascia the best. Temporal fascia melts away. I don't even use it anymore. I'll use the post-auricular mastoid fascia. I like it because it's thicker and it lasts longer. I mean, and of course NASM does rectus fascia is, I think, the best, but it hurts and it's another scar tissue. And then sometimes when the patient doesn't want any other donor sites, I'll use an allograft. I'll use alloderm or a cellular dermal matrix. But be very careful when you do that. Make sure you put betadine in, and I put those on antibiotics. And always irrigate out. Make sure you betadine them, and I put those on antibiotics. I actually have them use post-op mucoparison inside their nose 4 times a day for 5 days. You got to be careful. When you rib grafts are pretty resilient, but when you add another graft like a cellular dermal matrix, you really have to be careful.
Okay. 2 comments here. Briefly, no, this is not going to be recorded. We're doing this live, and for patient confidentiality, we're not recording this for anybody. The thick skin, Dr. Kobo is going to be talking about that next week. So a question in secondary rhinoplasty. After the end of the dorsum tip, when closing and the skin's too short, it doesn't want to close, what do you do?
In other words, you've redone the secondary and you've got ribbon there and you can't, and it doesn't close the
I think you can't close that columella incision. What is your conduct is a question.
Well, I think, that shouldn't happen. But yeah. I can tell you, if you've done that, then you need to do a couple of things. There's a couple of things. You can undermine the feet of the medial crura, around the medial crura. You can bring the columellar up. That'll help you a little bit. And then if you can close that incision with a 6-0 nylon without going through the skin, it's going to be fine. If you can't, then you've got to do something with your framework. I mean, and some of the patients I showed you, you know, that I did the framework as much as I could, and I barely could get them closed, like those secondary cocaine noses. That was a big constriction, was the soft tissue closure. So if you can close it with a 6-0 nylon, and sometimes I'll use a deep vicryl there, 5-0 vicryl, then it's going to be fine. But you can undermine it. You can undermine it inferiorly to that'll bring you 1 or 2 millimeters more. But if it's really out there, especially in like African American noses, sometimes I can't. Then you just have to take the tip graft off or do something. You know, and obviously I've had that discussion with the patient before, because that's a real issue.
Okay, I'm going to have to bring this into land now. There are a lot more questions. One last question I see that's come up is, how long do you leave the alar sandwich on for before you're removing it?
A week. And when you put that on, make sure you can stick your brown essence below it. Don't make it tight, and put in 2 or 3 sutures like I showed you. And just make sure, because you're going to get soft tissue swelling there. As long as you can put a forceps between it comfortably, you're not going to make it snug. And that's 6-0 nylon sutures. And use silicone. I used to use a bunch of other things. I now use the Zomed because it's soft, and I put it external and internal. It's like a sandwich. And it really helps to really keep that dead space closed, because the worst thing you can do is do all that wonderful work, and then guess what comes in there? Blood. And you know what happens to blood? It turns into scar.
Yeah.
You may wonder how I
know.
So.
Prof, I sincerely just want to thank you so much. We had nearly 300 people on the call this evening from around the world, and everyone had questions, and we could only take some of them, but we really appreciate what you do for us around the world and teach us. And I do hope things settle in Dallas for you as well.
You know, I sure hope that, you know, everything's going to be fine. We'll be better than ever. Just remember that. Okay. When we're done. So thanks so much. I look forward to seeing you guys soon. Okay. Take care. Be safe. Okay. Stay home.